Am I on? I removed my necklace this morning so I wouldn't be crashing around in conflict with the microphone. I'm so delighted to be here and to be part of your program today. You are embarking on, I think, a fantastic journey that is really going to be making a profound difference on the lives of seniors and their families. And I love the focus. Hey, Vicki, how are you? Love the focus on the development of capacity and skills that all of you are building yourselves, as well as helping to make each other strong. And as you come together at events like this, it reminds me of a session that I've read about and had the good fortune to talk to some of the people who were actually there. 15 years ago in Strasbourg, and there was a gathering of about 54 people from all ages, all different backgrounds. There were physicians, there were patients and families, nurses, other healthcare providers, IT professionals, people from the private sector, and they had one job over the course of 4 days, and that was to imagine a future. And what they did is the future of healthcare, in part of their thinking, they came up with this notion of a land of people power. And the land of people power was the way in which they ended up describing all the things that would be in place if it was an ideal future for healthcare. And this was a very profound focus at the time, because they were asking themselves some pretty tough questions around what needed to be in place for the individuals to feel like they had control over their own health, control over their own information, feeling like active and full participants in all of their care and in their full experience, not just the hospital, not just home, but in the community, in that full spectrum of their lives. And they focused on the health part of healthcare when they were imagining the future. And there was a brilliant nurse from Norway that was there, and as she listened to the description that people, including Dawn Berwick, who was there, the guru of all things quality, and she put up her hand and she says, you know what we're saying? This is a place and a future that I think is represented best by the notion of nothing about me without me. Nothing about me without me. This is the essence of patient and family-centered care. This is at the heart of the movement that's happening around the world right now, where people are saying, you know, enough. We've been getting good care. We've been participating in the system as you have arranged it for us, but we've been falling through some cracks. And in fact, the best expert on my health and my wellness and my life is me. Now, the voice of the patients and families themselves is slowly penetrating our great, big, traditional, hierarchical, cumbersome, is sounding familiar, systems that we've built in place over the years, that many of us who went into the professions, myself as a nurse and you as other kinds of providers, we went in with all the best intentions. But we've built a set of systems and processes around ourselves. How many people have ever been on shift where you say, oh, that was so great, there were no patients? And you think, what's that all about? So over the years, as this land of people power has started to take shape, the notion has been catching on as people have been challenging each other's ideas to really think about what would it be like if patients and families ran our system? What would be different? Take a moment and write down 3 things that come to mind. If patients ran the system, if patients ran your hospital, if patients ran your program, what would be different? Okay, who's going to share? Sir? They'd made more decisions all around their length of stay? Okay, what would be different? They would just be, is the different part that they're participating?
Yeah, they decide when they feel ready and when they feel
Uh-huh.
that they're improving.
So they're going to be part of the discussion around when it's time to leave, not just us, here are your bags and off you go. Okay, what else? Yes? So what does that look like?
Well, just it would be focusing on what's important to the person rather than what's important, what the system pressures are. So it might cause the providers to look a little differently about system pressures in the context of how the person's experiencing it.
That reminds me of another amazing Don Berwick quote. I'm a groupie of his, and I had the chance to meet him, and it was like take the selfie and everything. It was incredible. But he talks about not just what is the matter with you, but what matters to you. And that, I think, is what you've captured really nicely as the focus of a conversation with patients and families. What else? What else would be different? We have a gentleman who's been on your panel before. Sir, what would be different if patients and families ran our system? We would all be smiling. You know, the challenge, once you start to think about, oh, we've got another one, fantastic.
We would talk about feedback as feedback rather than complaints, as things that we could take seriously to improve.
We would be talking about feedback, not complaints, absolutely. Let's take a couple of more.
Get more educated as far as like following through. Oh, sorry about that. I'm loud enough. Or following through with them, so they know where they're going, what's going to happen, what's the next step. So keeping them more educated.
Okay, they would be more educated. Do one more and then yeah.
Their environment would be tailored to their abilities and health needs.
Their environment would be tailored to their abilities and health needs. Fantastic. We'd have to listen more. It would feel different, wouldn't it? It's incredible once you start to think of and go through the lens of nothing about me without me, and you actually start to think about what your day would be like if you took that one notion and everything you did that day was built around a commitment with your patients and families to nothing about me without me. Well, when I was at Kingston General Hospital, we challenged ourselves on that very front. And that notion grew out of a number of observations. When I arrived at KGH in February 2009, the hospital was in a lot of trouble. It was an organization that was in great financial difficulty. There were many challenges around quality and safety. Morale was low. And we had some of the highest infection rates in the whole province. And the government actually was so concerned about the hospital that they sent in an investigator and then a supervisor. Was really taken over literally by government for a period of a year. And I had the opportunity to come in and be part of the change and help work with the teams at Kingston General Hospital to move us forward. Now, at the time, we weren't really thinking about patient and family-centered care. We were thinking about a lot of the really tough challenges that a lot of us are facing every day with our finances and with all the other things that I listed. So, faced with such daunting challenges, one of the things that I thought would be helpful was to go out and listen to people. Exactly what you were talking, listen and learn from others and see what was on their mind, what were they thinking. Ask people 5 questions. What about KGH needs to be preserved and why? What are the top 3 things that need to change and why? What are you most hopeful I'm going to do? What are you most concerned I'll do? And what advice do you have for me? And got some incredible input. And all the time I was thinking about this as I was listening and learning from staff and patients and families, we put an initial plan together because what I had heard was this notion of people's really strong desire to live their aspiration of outstanding care always, every patient, every day. And we actually started a strategy project where we went out and talked to even more people, about 3,000 people. We asked them, what does outstanding care always look like? What does it feel like? Describe it. What happens when that happens to you? And we asked people about our guiding principles. What does respect look like and feel like? What does engagement look like and feel like? What is accountability, transparency, and even value for money? What does it look like? What does it feel like? And at one of these sessions, as I was working and learning and listening to people that was going to help us figure out where we needed to go, a woman stood up in a session, and she was someone who had spent a lot of time in our hospital, and she said, Leslee, I'm afraid to go to your hospital. And I thought, you know what, I can handle, I don't like the food, I can't find my way around. These are things that I thought we could fix. But how do you fix fear? Fear, right at the heart and soul of the patients and families, was something that really struck us as essentially at the heart of what we needed to unlock to move forward. And we actually, as we were shaping our new mission, our new purpose, we wanted to articulate what we were doing and going forward, and we had this notion of becoming a community of people, not just the hospital and the 4 walls, but a real community of people who were working together. The core purpose, that it was like the chorus that I kept hearing, was working together to transform the patient and family experience. And as we're getting ready to kind of build that out and present that to the board, thinking, okay, this patient, there's a couple of things around this notion of transforming the patient and family experience. And I thought, you know, how can we be so short-sighted in thinking that we are going to do that ourselves? Remember, this is almost 8 years ago. People weren't talking about patient and family-centered care like they are today. People aren't talking about patient engagement like they are today. But I remember watching, and we knew we had a lot of work to do around about patient safety, and watched one of a video again with Don Berwick and talking about this quest to eliminate all preventable harm to patients and families. And I thought, oh my God, that's what we have to do. If we're going to eliminate fear, we have to actually eliminate the harm. And because if that's what they're fearful of, and we've got evidence to say that we actually are harming patients and families, how do we tackle this? So we put a few stakes in the ground. We said we're going to eliminate all preventable harm to patients and families. We're going to eliminate all preventable harm to staff. But this notion of being a community of people, transforming the patient-family experience, kept gnawing at us, and then the penny dropped. We said, you know, this is a culture shift, and we all talk about culture shifts in our organizations, but what does it really take? What is culture shift all about? To me, culture shift is about what happens when nobody's looking. That's culture. You want to find and understand your culture, you're going to look and you're going to say, this is what's happening when nobody's looking. When people make decisions in the moment, they reflect your culture. You don't like the decisions people are making, it's a reflection of your culture. If people are afraid to make decisions, it's a reflection of your culture. But we thought if we're going to be true to this notion of nothing about me without me, and go down a path where we actually are building this community of people, transforming the patient and family experience, we need to do it with people, with those that we thought initially we were so bold and arrogant to actually think it's our job to transform them. It's our job to transform everything about the patient and family experience. Well, we miss the point when we think about that. So we decided to embrace the simple notion of nothing about me without me, and to say we're going to go down a path and we're going to put a stake in the ground. We're going to say, if we actually believe that every decision in our organization where there is a material impact on the experience of patients, a patient will be at the table. Now, we had no clue how we were going to do that. No idea. I got a couple of my KGH colleagues here that were really instrumental partners in helping to make all this happen. But at the time, I think it's fair to say we really didn't know what we were doing. But we decided that on principle, this was a vital step. So we went down a path. We pulled together a couple of folks that actually, when you talked about, someone talked about moving from complaints to feedback, we actually had a few folks in our organization that really had very deep concerns about the organization, some patients and families. And their stories about their experience in our hospitals were very hard to listen to, much harder for them to experience. So we invited them in and we said, would you help us? And that was the beginning of our first, what became our Patient and Family Advisory Council, which was at the beginning about a handful of individuals who had these very, very difficult experiences in the hospital. And these are the folks that a lot of people, when they now set up Patient and Family Advisory Councils, they run away from these folks. They say, no, we don't want them in there. They're going to cause trouble. Or they're going to be too difficult. Or they've got an axe to grind. Well, we decided that we needed to be learning and listening and figure things out together. So they worked with us to set up those first terms of reference for our Patient and Family Advisory Council. And we started on a journey that really was 7 years in the making. That now is, I think it's fair to say, that there really isn't a decision that's going on in the organization where people don't almost automatically think about, well, the patient voice needs to be at the table. How are we going to include them? What would they say? And then how do we actually figure this out together? So I'll share a bit about the learning that we've had and give you some examples of some of the themes that are also coming across, not just at organizations like KGH, and many of your organizations have been along this journey as well, but internationally there's some phenomenal, phenomenal work that's happening right now. But in the early days, because every time I think the lessons are still relevant, because every time you start an initiative and you're part of a project, you're bringing new people together, it's like a brand new day. And you're starting afresh. And the kinds of things that became important to us early on were going after that very simple advice that a lot of us get of going and doing something initially that's really going to be meaningful and reflect what you've said. Because the moment that you say that you are on this path, you darn well better live by it. Because the moment you say that you're committed to involving and engaging patients and families in decisions, and then you don't, you lose the trust, you lose the momentum, you leave people behind, and it's very, very hard to pick up. If you declare that you're on a journey to figure it out and to get stronger and better all the time when you're going forward, people will come along with you. But don't do it with posters and banners and big rollout excitement. We didn't do any of that, frankly. We decided that we were just going to kind of go and learn. So a couple of our folks went to conferences, like with the International Patient and Family Centered Care Conference, the Institute. They came back so excited. And Vicki, you were one of the very early ones that went. And it was like this incredible experience for people. And they came back with all kinds of ideas. And they met some folks from Georgia. And they met some folks who were further along in the journey. And in fact, the folks from Georgia region, they ended up becoming our partners and learning and coaches because we decided that we were going to keep in touch, exchange ideas. And then as we were going through some of the process, we invited them to the hospital to come, and they would come and they gave some workshops. They talked to our staff, they brought some of their patient advisors, and they became like our mirror. And it was a really interesting process. These weren't consultants. They were just partners that were interested in supporting others that were on a journey like themselves, where there was very few of us, and we kind of felt like we were out there on our own, but we just were doing what we thought was the right thing to do. And what they encouraged us was some of the just do it mentality. So we really adopted that, and we would do things and make some mistakes and kind of figure it out as we went along. So, but early on, we listened too. And we did some of the hard work up front to declare and to show that we're serious about change. And one of the very early changes is now much more commonplace, but at the time, one of the patients and families around the council, they said, well, what is it about visiting hours? And, you know, we didn't have a very good answer. And so we started to explore this notion of visiting hours. And one of the patients, the women, or the wife of a woman, she said, you know, I'm a wife. This is my husband. This is our daughter. This person's a friend. We're not visitors. And they talked about the experiences of when they were present, the difference it would make in the lives and the experience of their loved ones when they were in the hospital. So in listening and learning about that, we said, you know what? Let's do this. So off to the Nursing Advisory Committee, the recommendation went to eliminate all restricted visiting hours. Well, how did that go? Well, that's one of those self-reflective laughs. You've been there, right? And you kind of think, well, and I used to be an ICU nurse. Well, that's when we got our work done. When the patients and families were out of the way. That's when we talk about things. We talk about them. We do stuff when the families just weren't around. But as we listened and thought, and the nurses were really quite nervous about this, because again, this is when we got our work done and all those other things. There were people who were worried about safety. They were worried about a variety of things. So we listened to what the concerns were. And we made some changes in our own processes. But pretty quickly, we adopted what initially was an open hours visiting, or open hours. We ended up shifting our language to family presence. as opposed to visiting. And now we have family presence policies, not visiting hour policies, that respect and honor the individual patients' and families' wishes, and family is who they decide it is. What a beautiful notion. It just makes sense. Think about in your programs, think about who's allowed in the room, in the consult room, in the whatever. Are you immediate family? Well, I might be the neighbor and the only person who's taking care and being with that individual. I'm not immediate family. But if the patient decides that I'm the one that they want with them, who are we to place judgment on that? So we did the experiment. We opened up the restricted visiting hours, and now it's been over 6 years, and it's been a remarkable experience. I don't think anyone would imagine ever going back. But it was the start of the shift of these subtle things, other parts of cultures. The way we make decisions around nothing about me without me. Any material change in the organization that has an impact on the experience of patients, a patient family will be at the table. So how do you do that when you think about all the decisions that are being made in your organization and in your program? Well, you actually start to unpack things and you figure out where people can be involved. So we grew the Patient and Family Advisory Council. We grew a role called the Patient Experience Advisors, and now there's over 60 Patient Experience Advisors at KGH. And these Patient Experience Advisors are part of all the program teams. They're part of all the planning. They are part of every committee in the organization where there is where people are talking about things, where there's a material impact on the experience of patients. You think about your organization, you think about where some of those discussions and decisions are made. And I'll tell you, I never would have imagined some of where patients and families are involved. Never in a million years would I have bet that a patient would be on the operating room committee. That's where OR time is allocated. That's where the docs come and duke it out for the amount of operating room time that they're going to get in the schedule. And then when you think about, you start to reframe, you say, okay, well, what is operating room time? Operating room time is about the use of a precious set of resources to take care of our patients. And then what they would do, as soon as a patient is at the table, the conversation changes. We had patients and families on our patient flow committees. Now, I've been in this world for 30 years, and we're still trying to figure out how to get a patient from the ER up onto the unit. We're getting better at getting people out, but not the right ways. And so patient flow. But then you talk, you think, you close your eyes and you listen to the last conversations you've had. And you might hear the terms like bed blocker, the problem, the ALC, the demented man in room, even if it could be even the dementia in bed 4. We depersonalize people at every turn with our language. And if you want to shift culture, you pay attention to language. And so when a patient is at the table, you don't dare call that person, a patient, an it, a bed walker, a bed 4. So people start to learn and experience conversation in a different way. And this is part of the change. So by putting these stakes in the ground around how we were going to make decisions, involving and engaging these patient advisors, we now have patients and families, again, on all these committees and processes, and we have them shaping the very nature of our organization at every turn. Has it been easy? No. Have we made some mistakes? Absolutely. Have we learned and just kept kind of dust ourselves off and keep going? Yes, because we really adopted the notion of being, we didn't call ourselves a learning organization, but I think that's essentially what we've been. We adopted a continuous quality improvement mentality. But most important, when we think about the success over time, it's been a very, very clear and deliberate strategy. Very clear, and everything in our organization has stemmed from that clarity of purpose and the clarity of direction, how we monitor ourselves and figuring out how we're working and how we are measuring and are talking about our progress, how we evaluate ourselves as individuals as well as our organizational performance. We even had patients and families talk about, well, what are the most important decisions that we make in the hospitals? And probably number one is who you bring onto your teams. So patients are on our interviewing committees for staff, for frontline staff. And you say, well, no, that's HR's job. Well, what a telling experience for new staff who are being recruited into your organization, and you say you're patient-centered, and now staff will say, I chose KGH because you didn't just say you're patient-centered. I met a patient when I was being interviewed for a frontline staffing job. That is the place I want to be. And this is remarkable. And so they are everywhere. And there's lots of different ways to create presence. And it is the notion of presence that's the most important. We have, with their guidance, developed standards around patient and family-centered care. And what we've done is then with those we measure and monitor how we're doing. And there were a lot of things that you would expect and now are quite commonplace in organizations, but they weren't at the time. So things like the whiteboards at the end of the beds where there's a lot of good evidence to support the fact that, who's on the care team, etc. The notion of purposeful hourly rounds, this is one of my favorites, actually introducing yourself. And there was an observation from patients and families. So what they said is, have you ever seen the name tags that people were wearing? Usually really small writing, and then people flip over the name tags because they don't want you to actually know who they are unless they decide to tell you. And what's on the back of the name tags? Codes. Have you ever read that? Have you ever been in bed reading and you see bomb scare, missing patient? They said, it doesn't actually give us a lot of confidence. So they said, well, we want to know who people are. So let's put the name, big letters, Leslee Thompson, and my role. And then someone said, and you know what? Make it on both sides. So you cannot flip it over and have a code. It's the same thing on both sides. We thought that was a brilliant idea. Everybody in the organization got the new name tags. But the interesting thing was, think about culture change. It's not just about coming up with a great little brilliant idea and say, woo, we're done. Everybody has to wear them on their left or on their chest height, left or right, chest height. Why? So you can see it. I really, these lanyards are nice, but it is not a place to put your name when you've got a patient and when you're working with patients. They have to kind of go down and see what you've got, if they even are able to attempt to see that. Must be in a place where people could see it. Big writing, you know all about senior standards, seniors-friendly hospital standards. Big writing, both sides. And then it's about what happens with the name tag. Hi, I'm Leslee. I'm the president and CEO, and I'm here to talk with you today. Nice to meet you too. That is the interaction that becomes the standard. The whiteboards, just because they're filled out, we realize that just because you fill them out doesn't actually mean anything's happening. It's like even when I was a family member going to a hospital that they said, well, they had posters and signs everywhere about patients involved in shift change. Well, what happened, they did in-room shift change. They'd come into the room, They do their shift change, and we'd be saying, hello, it's us. They didn't talk to us. They talked to themselves, they did the shift change in the room, and on they went. That's not patient engagement. That's not nothing about me without me. And so if you start looking and unpacking every single process, every single interaction, and you think about what would be different if I made the declaration of nothing about me without me in every single interaction, what would be different, and make it different. Because the reason why we were successful at KGH, and we're still on a journey, is because we just kept taking the steps and moving forward. It was an iterative process. It wasn't a grand design initially, but it has become, it was like I was watching a tweet the other day and listening to through the social media and listening to a patient. I nearly broke into tears because I wasn't actually at this meeting, and she says, patient and family-centered care is not what we do, it's who we are. It's who we are. So what can you do as leaders in your programs, in your organizations today? So in fact, as we were going forward, and I kept saying, okay, because one of the really important jobs of a CEO is to actually, when you'd say, what do you need from me? What can I do? And they say, just keep smiling and get out of the way. And that's a really important job to have at some times. But I kept saying, well, what do I get to do? So I really started to explore and think about leadership in a different way. How do I exemplify patient and family-centered leadership? And we came up with really 4 things that's part of what I would call a leadership practice that anybody can take tomorrow, today, and start practicing in your own environment that brings to life the very essence of patient and family-centered care as we've been talking about so far. And there's 4 things. The first is actually thinking about the reports and reporting. How many people have to deal with numbers? Oh, there's got to be more. How many people look at numbers? Okay. So one of the traps we were falling into in our organization is we'd still have a lot of monitoring and reporting, and it really was part of the depersonalizing experience for everything that was going on. So we came up with this notion called peopleizing the numbers. Peopleizing's not a word, but it's our word. And what does peopleizing the numbers mean? It means exactly what it says. It means turning the number, the statistics, into something that is meaningful from a patient perspective. I'll give you a very specific example. A patient who was at our infection control committee. The guys in the white coats putting up the numbers, and we're going to be improving our infection rates by 0.08% this month, or we did it. And she says, so how many people came to our hospital last month without an infection and then left with one because we gave it to them? That's hospital-acquired infection. And I challenge you, for every number, be it your wait times, be it all the ways in which you're going to be evaluating your action plans, peopleize your numbers. How many people were affected? Translate wait times, translate your budget, translate every single metric you have. Peopleize it. Because then you never forget the why. And I tried to set the standard of saying, I don't care about the numbers unless you can peopleize them. It's a big challenge. Because I have to care about a lot of things, but it really started us to think about and talk about the numbers and what they meant and why they were important. And that also has become part of a language that we can all understand. Peopleize the numbers. First part of leadership, you're looking at numbers, you're throwing out numbers, you're getting people to collect data on numbers. Peopleize them. It's your job, it's your responsibility to make sure that everybody understands the why. Number 2, ask yourself, everything you're doing, have I included a patient today? Now, you may not have an individual patient right there, or a person, a citizen, a family member. It's all part of a spectrum. But ask yourself, have I included the voice of a patient and family today in this decision? Ask yourself, and if you haven't, get one. You don't need the all the well-developed policies. There's so much information and resources out there. There's so many hospitals and organizations, home care, long-term care, others that are doing this. Places like the Institute of Patient and Family Centered Care borrow, steal, adapt practices that others have done and say, okay, how would I get this voice of the patient and family at the table? Invite them, and it might actually feel uncomfortable. And people will say, well, like, why am I here? And the staff might say, well, why are they here? This is our job. Well, no, our job is to work with, to discover, and to figure out what the experience of patients and families are so that we can end up building together the processes and supports to actually make that real. Have I included a patient today? Then, when you're out and about in your job, in your day-to-day, ask yourself as a leader one other question. What have I learned from a patient today? We're a learning organization. Well, what have you learned from a patient today? And I would say if you're a manager, you're an administrator, you're a clinical leader, if you can't answer the question, what have I learned from a patient today, you're not spending your time in the right places. What have I learned from a patient today? And then the best part of the leadership practice is sharing a story. Stories shape culture. Sharing what you learned from that patient today. Sharing something that you observed other people doing and saying, wow, I saw this, it made a great impact on the experience of patients, and then sharing that beyond. Catch it and pass it on. It's remarkable when you start telling people, talking to people about from the experience of what you learned, what you saw, how it made you feel. The difference between that and just going and putting a whole list of action items that were accomplished on a board. We talk about the importance of patient and family stories. I think we've got a lot of work to do on our own leadership stories, because that humanizes the experience of working with each other, and the stories that we can tell about what we learned, what we felt, what we experienced, helps humanize all the interactions that we have, which again then kind of softens up and builds a culture of sharing stories that is a very powerful, powerful platform for change. And so if you share those stories, you're peopleizing the numbers. You're asking yourself, what have I learned from a patient today? And have I included a patient today? And sharing what it felt like, what it was, what you learned, that helps build and shape a patient and family-centered culture. It's not that complicated. Thinking about nothing about me without me. This is really taking hold in a lot of organizations across Ontario. Some fantastic work by Health Quality Ontario, fantastic work by many organizations that are probably here in this room. The Change Foundation, there's research going on from the Li Kai-shing Institute in this area. There are forces right across the country with the Canadian Foundation for Healthcare Improvement. And now I'm so excited, at Accreditation Canada in January, the Patient and Family Centered Care Standards were launched. And it is a really fantastic translation of people's commitment to say, we can't just talk about it anymore, we got to actually understand how this is reflected in our behavior, our conversations, and then moving to the so what. Does it make a difference? Well, we've made many, many accomplishments and changes in our own organization that we're just absolutely thrilled about, that is real hard evidence that this is an essential part of the change. We would not be where we are today without the voice and the active participation of our patients and families. They helped us turn directions we never would have imagined, and we are all the better for it. In other places across the world, there's movements of, there's a hashtag called Patients Included. And the Patients Included standard is now becoming a global standard. What says that some people will say, I'm not going to a conference, I'm not going to speak at a conference, or we can't have a conference unless patients are included. So we've got one gentleman, and you've had others before. Think as you go forward how different the conversations would be in your teams if you had a patient at every table, a family member at every table, and you're figuring things out together. Because as one of the most powerful insights from one of the patients who I've gotten to know, she's someone who lives with chronic kidney disease. I've sat with her in her home as she gives herself dialysis, and to learn what that's like. And she calls herself a lived experience expert. I love that notion, because what she does is she helps unfreeze this notion that we are supposed to be the experts. Well, some of us are experts in some things. When you work with physicians and others, they are experts. But she says, you are an expert in the things that you know and you went to school. I am the expert on me. I am the lived experience expert. And together, we're going to figure all this out. If you look at every patient and family member as the lived experience expert in their life, all of a sudden they're not the patient. They are a life. They are the expert in their own lives. And it is our job to discover where their strengths, where their hopes, where their dreams, what matters to them, not what's the matter with them. Practice some of these techniques, practice some of these interventions, take the step, and I guarantee you, you will never, ever look at the world the same again. Once you start to live the practice of patient and family-centered care in its bones, unpack all the rhetoric, take away the banners and the balloons, live the commitment to nothing about me without me, and you will make a profound difference in the lives and with the lives of those patients and families who you're here together to figure out how to serve better and to enrich their lives. And I wish you well on that journey. Thank you.
When you go back to your hospital to implement your improvement plans, have patients and family members on your improvement team with you. I see some. Deborah, you have a patient involvement on your team as well.
We have a patient in our working group for senior friendly.
Yep.
So,
Patient involved in the working group? Yep.
so many of you do. In cohort 2, we actually have some hospitals that are bringing patients with them for the full 3 days of the workshop that will be taking place in the next few
Fantastic.
days. So please feel free to go up to the microphone. And do you have any advice for the hospitals to, in particular, engage older patients and family members with issues that are relevant to them in this process?
Well, I think that the most important thing when you go down this path is that the patients and families that you are involving, there's different levels, right? There's the individual care level, there's at the organizational level, and there's the kind of the policy level. It's all part of a spectrum. But if you're focusing on the organizational level, if I just speak to that for a moment, the patients and families that you involve and engage must reflect the populations you serve. If you have a whole group of patients and families that are Rhodes Scholars and you're serving the inner city, that's not going to bring you the insights that you need to understand the people that you're serving. And there is a way to work with everybody. And so you need to have the diversity of socioeconomic status, the diversity of language, the diversity of age. And I think that, well, how have we done with our old folks? Yeah, how have we done with in the seniors program, Bernie?
Well, we're getting there.
Yeah. Stand up so people. Bernie is one of our nurse practitioners and at KGH who's very shy, but not with patients, I can tell you. Yeah.
I think we have a lot of work.
Yeah.
Like anywhere we struggle to, yeah, I mean, we work with medicine, right?
Yes.
And the acute care center is huge.
It's not, oh, I don't like that.
Go for it.
It was a bottle of wine, I have no problem.
Yes.
But medicine program is very huge, right?
Yeah.
So you really have to, there's so many players, right? There's the acute patient, there's the patient with, at various levels of their trajectory, right? And many of the patients that we're seeing there are coming in hospital that are elderly, and there's just the numbers. I don't think the incidence of delirium or the incidence of the problems they are having is going up. It's just the sheer numbers of elder patients that are within our community, because our community is an older community compared to other regions. So there seems to be, and we're in Kingston, right? We have one inpatient hospital for the whole region. And it's a community hospital, but it's also a regional tertiary care center. So, I mean, you get everything in everything. And I think a lot of the things that we have done, we've made a great progress in elder care. And, you know, we now have a CL psychiatry with access, in-house Jerry psychiatry, which we didn't have, you know, 3-4 years ago. The patient advisors are on our program council, right? So we'll be taking our work there. They're everywhere in the framework when you go to develop things. We have a help program. I think we're doing very well. I think people get confused about many of the standards, and there's like this standard for senior friendly, and then there's this standard for accessibility, and people get that all confused. When you do one thing to help one group, it automatically helps the other.
Yeah.
But I think we're becoming very much more senior friendly. We got a ways to go. We've introduced the Move On with, I can only speak to the medicine program. We've introduced the Move On. We're doing the delirium. We're actually working as a group from medicine with the surgery department to start delirium screening in surgery, orthopedics. Believe it or not, medicine is going to work with the orthopedic people. I mean, there's a great relationship there. We're taking this and we're expanding it to other floors. You know, the basic level, you know, the Houdini project, removing catheters. I mean, the Move On project, you know, the health program, and the volunteer program is absolutely expanded greatly. We've got music, we've got pet therapy, art therapy.
And the patients and families that have been involved in every
step of the way. What do you want?
Yeah, that's right.
We actually have, I think we need to look at on certain, and what you've said, I think we've done a better job with getting our patient volunteers to represent patients. And like you said, we need to make sure that they're representative of the group.
Yeah.
And we're actually doing that. And
Good.
so, and we're making connections now within the institution. We're finally making connections with our community partners at a much more in-depth. So what can we do to improve, right?
Good. Thanks, Bernie. Those are great examples. Okay, good. Sorry, thanks.
Hi.
Thank you for a wonderful talk. I really, really enjoyed it. When you were talking about engaging patients and families, this is a question and a comment, I guess. I thought it's really important to, I'm a clinical nurse specialist and I worked as a staff nurse before becoming a CNS, so it was really important to do a family nursing assessment on admission, and I find that we don't do that often. So who's important to this person, especially when it comes to older adults? A lot of times if they have cognitive impairment, we need to speak to the family. And we need to know from the very beginning what their baseline is, what's important to them, how do they cope. And I know I've worked in 3 different hospitals. Some hospitals have a better emphasis on that patient-family assessment because we are so sometimes medically focused. I wanted to know if in your hospital, do the nurses do a proper, not a proper, but is there that family assessment, like Calgary family assessment model or the McGill model? I don't know if that's something, because I think it's a wealth of information there.
Yes.
And, yeah.
I'm going to actually ask Vicki to answer that question because she's much closer to the front line. Vicki's one of our amazing managers.
I'm one of the managers on the medicine program, and we identified the same need. And while we're not using a specific tool, we have instituted what we call care navigators, so a buddy for the patient. When the patient arrives in the merge, they go down and meet the patient. They do that assessment to see who the next of kin are or who the important people are, what functional assessment they're at currently right now, and then we use that tool as we go through the course during the hospital stay and to facilitate the transition home.
Thank you. And then that gets on the whiteboard. And the other thing we did is we moved all the charts to just outside the patient room. We are not as far along electronically as some others are, but we moved to the interprofessional charting. Moved also that the basic premises. It's the patient's chart. It's the patient's chart. It's the patient's chart. Right, so they have access, there's all the discovery in terms of just figuring out how do you actually have a welcoming environment where people can contribute to the chart, and that also now because if you've got the family members there and you're focusing through there, the thing that we're working on now too is around rounding, so that always it's patient rounds, not doctor's rounds, it's patient rounds. So when patients and families are included, and I know even when I was a family member in our own hospital and observing and experiencing being included in rounds, it's quite a remarkable experience. And we do that by routine now in the ICU, in the neonatal ICU and others. And even the skeptical docs have gone and kind of timed whether it takes more time. And the basic belief is that it actually is way more valuable to spend that time with including patients and families in the rounds and in the discussions, because where do most problems come from error? It's breakdowns in communication. And so by respecting and honoring the patient voice and including them in discussions. And now when you look at what's happening around the world with notes and electronic records, some of the phenomenal activities around patients really being the custodians of their records is changing the face of the interactions between providers and patients and families in a way that I think we've got a long way to go still, but I can tell you that's something that now that I have an amazing platform of standards nationally, that the notion of the patient record, we're going to wrestle that one to the ground.
Well, maybe I'll let you have the last word, Leslie, and tell us what is the biggest fear that we need to overcome in order to make this a reality, a meaningful reality?
I think the biggest fear is within ourselves. I'd say stop looking at everybody else. Stop thinking it's somebody else's job. Stop saying that your CEO doesn't get it, or your manager doesn't get it, or somebody else doesn't get it. Start with yourself. And if you can overcome in your own mindset and make the commitment in your own behavior to translate your mindset into behavior and own that. We went through this change one person at a time. And you can make an extraordinary difference by embracing the practices of patient-centered leadership, focusing on some simple things, sharing those stories of what's working and what you're learning, and overcome the fear and the thinking that you got to get it all right first. Just do it. And I guarantee you will never be the same. And that is in a very, very positive way. So own it yourselves, and you will be forever changed, and as will the lives of the patients and families that you are here to serve. Thank you.
Thank you so much.
Thank you.